Hi, very good evening to all of you. With this with the new financial year, we are again with the osmosis with the masterclass of the different cancer type, the different cancer stages, and the discussions with the different panels. So again, we are starting for this year as a financial year 2026-2027. This year we are started with the East chapter osmosis as a master class from diagnostic to the decisions. So today we have the esteemed panelist as well as moderator, Dr. Jogmaya from Bhubaneswar, Dr. Indranil Ghosh from Kolkata, and Dr. Amit Kumar from Patna. So they are going to talk on the three different cases on three different indications as well as the disease areas in the cancer. One is on cancer cachexia, evolving science and practice. The second case will be the on ovarian cancer, and the third case on will be on prostate cancer. With that small brief and with the welcome, I would warm welcome to all of you and thank you for joining with us. With that, I would like to hand over to Miss Anjana Yadav, who is our manager in Medical Affairs Samarth. Thank you. Hand over to Anjana.
Thank you so much, Saurabh. Again, I welcome everyone. Good evening, everyone. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana Yadav from the medical team of Samarth Life Sciences Private Limited. On behalf of the organization, I am delighted to warmly welcome you all to today's webinar, which we proudly present under our flagship scientific initiative, OSMOSIS. OSMOSIS is an academic platform conceptualized and driven by our oncology division, OnQuest, with the objective of fostering meaningful scientific exchange in the field of oncology. We initiated this program approximately 3 years ago with the vision to create a credible, knowledge-driven forum where experts could come together to share their insights, discuss evolving evidence, and deliberate on real-world clinical challenges. Over these 3 years, Osmosis has readily evolved into a highly valued and trusted platform for the oncologist. It has gained recognition for facilitating rich academic discussions, promoting continuous learning, and enabling the dissemination of the latest advancements in the oncology practice. The consistent participation and the engagement from esteemed oncologists across the country stands as a testament to its growing relevance and impact. Through this initiative, Samarth as an organization remains committed in contributing meaningful to the oncology community by providing a robust scientific platform to explore diverse topics. We therefore believe that Osmosis is not just a scientific platform, but also a powerful metaphor for knowledge dissemination. The focal point of our discussion that will be today are the three real-world cancer scenarios, which is a masterclass on diagnosis to decision. We are very fortunate to have with us the esteemed experts who will share their insights and experiences on these topics. Before we start, let me give you a brief about our company profile. Samarth Life Sciences. Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life-saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Since its inception in the year 1963 by Mr. Gunwantlal Shah, Samarth Life Sciences has been a prominent player in the pharmaceutical industry. Samarth Life Sciences operates through 13 therapeutic specialty divisions, each focusing on specific area of healthcare and expertise across a broad spectrum of medical conditions. OnQuest is one of the division that caters to the oncology specialty. We export over 250 products in over 70 countries, which demonstrates our global presence and commitment to serve the diverse market. We are also proud to share that Summit Life Sciences has received significant accolades and recognition, reflecting its excellence and influence in the healthcare sector. With this short brief about us, we would like to initiate the scientific program. Today, there will be three case presentations on various topics, like the first case presentation will be on cancer cachexia and evolving science and practice. The moderator for this case presentation would be Dr. Indranil Ghosh, who is a medical oncologist, Apollo Hospital, Kolkata. The second case presentation would be on the real world case presentations on ovarian cancer, and the moderator for this session would be Dr. Jogmaya Patnaik ma'am. She is a medical oncologist at Kalinga Institute of Medical Sciences, Bhubaneswar. And the third case presentation would be on real world case presentations on prostate cancer, and the moderator for this session would be Dr. Amit Kumar, medical oncologist, Medanta Hospital, Patna. With this, I would like to initiate the program and start with the first case presentation with Dr. Indranil Ghosh sir. Dr. Indranil sir, are you there?
Yeah, I am here.
So do you want me to introduce the panelist, or you will do it, sir?
I will do it.
Okay, sir. So with this, I would like to hand over the session to Dr. Indranil sir. Over to you, sir.
Yeah, so very good evening to all of you. I would like to welcome my panelists. I think they are all here. Dr. Sanchayan Mandal,
Yes.
medical oncologist from Kolkata. Dr. Victor Mandal, medical oncologist from Kolkata again, from Apollo only. Dr. Gaurav Kumar, palliative
Hi.
care specialist from Tata Medical Center. And who was the fourth one?
Dr. Victor, sir.
Victor, I told.
Sachin Shekhar Biswal.
Dr. Sachin Sekhar.
Victor Biswal from Odisha. Medical.
Bhubaneswar, yes.
Okay, so this case discussion is about cancer cachexia. I must say that I am not an expert on this field, but yes, we can learn a lot, especially from Dr. Gaurav. The objectives of this session are to recognize cachexia early, understand why nutrition only fails, clarify the role of various pharmacologic therapies available, the role of communication with patients and families, and focus on the practice-changing insights. So question is why cachexia is not simple starvation and why nutrition alone fails. So we'll go to Dr. Gaurav straight away to know your thoughts about this.
Yeah, so my internet connection is a bit wavy, so
We can
I'm
hear
gonna,
you loud and clear.
yeah, okay. So yeah, that's a very typical first question that comes to the mind, that cachexia and starvation. See, starvation is basically deprivation of nutrition, which actually leads to the clinical effects, which does not meet with the body's need. But cachexia is a very
No, now there is a problem.
derived from the Latin word. Hello, I'm audible.
No,
Yeah,
last few words we could not hear.
yeah. So cachexia has been derived from the Latin word cos and helios, which means bad and condition. So it's a multidimensional condition syndrome where there is a progressive decline in the skeletal mass, and which is not supplementation. So it may be with or without loss in fat. And cachexia, the definition has been defined by different working group, but there is one very practical Italian definition which categorizes in body weight along with either of three symptoms of anorexia, early satiety, and fatigue. So more than 10% body weight loss in the last 6 months with either of three will define the patient to be in the range of cachexia, and pre-cachexia is less than 10% of that. Now, will giving nutrition alone reverse this condition? The answer is no, because cachexia usually happens in chronic life-threatening diseases, cancer, AIDS, these are the main areas where cachexia has been seen to be evident. And it is mainly because of the acute inflammation. Now, cancer being a highly catabolic condition, the inflammation, it is very difficult to tide over the inflammation. So there has been studies which show that nutrition may help in the pre-cachectic condition. But once the cachexia develops, then the nutrition optimization also does not help. So there are different targets thereby which actually addresses the cachectic patient.
Yeah. So, very well said. So, we'll go into those intervention later. So, this is what it is. Cachexia is an inflammatory and metabolic syndrome. The tumor-driven cytokines alter the metabolism with the central appetite suppression, and feeding alone will not reverse the muscle loss. The first case, 64-year-old female with metastatic breast cancer, ER positive, HER2 negative. BMI is in the obese category, weight is stable over the last 3 months. She says, I feel heavy and weak and I can't climb stairs anymore. HbA1c 6.8%, CRP slightly elevated. So, Dr. Sanchar, so when do you identify cachexia and do you routinely screen for weight loss or sarcopenia?
Yeah, good evening, sir. Basically, cachexia is just like as Dr. Gaurav told, it is when we have seen many patient may present at first upfront before the starting of the therapy also. So before the starting of the therapy, especially chemotherapy or concurrent chemo radiation, so we have to assess how much weight loss he has actually lost in past 3 months to 6 months, and also overall fatigue, whether he is able to walk by himself or also due to the fatigue or due to loss any muscle loss in these 3 months to 4 months. And on the therapy, when we are continuing, suppose chemotherapy or multi-day chemotherapy or concurrent chemo radiation, when my practice is when the patient comes every week, we definitely check for the weight, how much weight he has initially at the time of the treatment, and every week when he's coming either by concurrent chemo or chemotherapy or 3 weekly basis, we definitely note down the weight loss, how much weight loss is happened, and if it is more than 10%, then you have to definitely modify the dose of chemotherapy also.
So this patient did not have any weight loss, but only complaints of weakness.
Yes. So this patient, in case if the patient is overall stable BMI but feeling weak, that may be the inflammation or cytokine released by the tumors. So we have to keep track and see is there any weight loss, and we have to observe her closely for the weight loss and further recognitions of the these things, cachexia.
Right. So, Dr. Sachin, uh, can you say what are the signs you are looking for early recognition of cachexia?
Good evening, sir. For early recognition of cachexia, sir, uh, we would have to look for the nutritional status of the patient as well as any history of weight loss. Cachexia usually is an unintentional weight loss after diagnosis. It may be nutritional or maybe very advanced cancer patients might be having it. So the early signs that which we focus on, it is definitely one is weight, other is loss of fat and muscle, and signs of wasting like temporal region wasting and wasting of muscles. These are all the signs we look for. And in investigations, we usually look for albumin.
Yeah. So are we following any of these indexes? Let's go to Dr. Gaurav. Dr. Gaurav?
So, honestly speaking, we define it on a clinical parameter, and Dr. Bishwal has said that the serum albumin level. So, the University of Texas staging system, we don't follow in our practice. So, I don't know whether you have that in your system in practice.
We are also not following this. It's mostly simple, and we are not doing this body composition analysis also. So just skip this. So cachexia often precedes advanced disease, and uh, more than 10% definitely is significant, but less than that also we need to look into, as it can be pre-cachexia. Sarcopenia may exist even with normal BMI, and appetite loss is an early warning sign. So Dr. Victor has not joined, I think. I don't see his name. So Dr. Sanchan, do you currently rely on the BSA for chemotherapy dosing, and can it mask the sarcopenia and can lead to overdosage in some of these hidden cachexia patients?
Yeah, sir, we generally do the BSA based dosing. And if we see that there is much loss of weight and cachexia due to the cachexia persisting, not gaining the weight, patient completely feeling weakness, and there are multiple intolerance to chemotherapy, like due to the weakness, patient the performance status is also getting down. Then definitely we have to change the dose, especially that dose may be not tolerant to the patients. We have to reduce the dose, and once the patient along with the supportive therapy or other oral agents if we give, and then in coming weeks if they improve on the both the energy fatigueness reduce, feeding improved and weight are increased, then we can also adjust the dose later on.
Yeah, so it is multifactorial. So there can be a patient with a BMI normal or low normal. So if patient is having anorexia and recent weight loss, then a full dose may not be tolerated. So we have to modify accordingly. The patient response, we can increase. The next case is 58.
Sorry to interrupt, Dr. Victor had joined.
Okay. So 58-year-old male with pancreatic cancer, weight loss 9% in 4 months, BMI 19, anorexia is there, early satiety, nausea, albumin 3.2, neutrophil lymphocyte ratio is high, that is 5, resting inflammation. Dr. Victor, are you there?
Excellent. Yes, sir.
Yeah. So let's say it's a non-metastatic patient. So whatever evidence has been given regarding the nutritional parameter, is it strong enough for you to delay a major surgery for 2 weeks to optimize the nutrition, or the fear of tumor progression is too high?
Sir, we may optimize, sir. After that, you can go, sir. Hello?
Yeah.
Sir, actually, sir.
Yeah, this is the status of the patient, non-metastatic. Weight
Yes,
loss,
sir.
weight loss is there, BMI low, anorexia, albumin 3.2, NLR high. So upfront surgery, will you advise, or you will advise for 2-3 weeks of nutritional optimization?
Sir, I will advise nutrition optimization. Let her performance set a little bit optimized. After that, I can opt for the surgery, sir.
Okay. So now in the palliative setting, many times we have to give some medical therapy as pharmacologic therapy. The two common drugs available are megestrol and olanzapine. Dr. Biswal, do you prescribe megestrol?
Yes, sir. Yes, sir. We prescribe Magistrol on a routine basis on for advanced cancer patients suffering from cancer cachexia. And the patients, how do I choose Magistrol? The patients which we are planning to continue treatment for a longer time. So in those patients, we need the appetite to improve, or the patient should suffer less from sarcopenia. So in those patients, for example, the pancreatic cancer metastatic patients in whom we are planning 6 months of chemotherapy. In those patients, we usually choose Magistrol acetate. And if the goal is to, if the patient should feel better, then we usually choose olanzapine over Magistrol, sir. Like a patient on best supportive care and on routine follow-up for symptoms. In those patients, we choose olanzapine or steroids.
Who should not receive megestrol?
Diabetic patients mainly, sir. Uh, Diabetic patients and uh, patients who are on best supportive care, who uh, the diabetes is difficult to manage, or patients suffering from edema, because edema is one of the adverse effects of megestrols.
Yeah. And what is the dose typical?
Usually, sir, we keep it 160 mg BD, but depending on the requirement, we can go up to more than 600 also in some patients.
Right. Dr. Shanchan, what dose?
Sorry, sir.
What dose and what are the adverse effects of megestrol in your practice?
Okay, dose I use that doctor told that 160 mg twice a day, and sometimes due to the cost issue also we have to start from the lower dose 40 mg once a day or twice a day. And most of the side effect we have seen that edema, and there are written side effect of venous thromboembolism. But in our practice, I could not find any patient due to the menstrual DVT. It may be due to the cancerous that caused the DVT. But edema we can find in our patients. But most of them are well tolerated. We did not find any much side effect.
Right. So it improves the appetite and weight, but it's mostly fat and does not improve the muscle mass. Best for a short-term palliation. Edema is quite common, but VT is also mentioned, and obviously we won't be able to distinguish it is due to megestrol or due to the cancer. So we need to be aware, and at least those who are on treatment, we can give the DVT prophylaxis as appropriate for that patient. What about all these drugs? Dr. Gaurav, any experience with any of this?
Yeah. So steroids we used commonly, that's kind of an alternative to magistrol acetate. So steroids have been shown to increase the appetite and the general well-being of the patient. So it kind of brings about a improvement in the quality of life for a short duration of time with its own adverse effect profile. With regards to anomarelin is something which has not been marketed here in India as far as I understand, and it has it has been studied well in two Romana trials in Harvard. So has found to increase the lean body mass, which is actually the main target, the for treatment of cachexia. So anomarelin is a very promising molecule, I would say, that has a very potential futuristic impact. It has not been approved by FDA because they had a hand grip test and which did not work out in that. So a very not a very meaningful way point to reject that. It is still being tested, and cannabinoids we have Ayurvedic formulation. For us to prescribe cannabinoids is not legally allowed. So we don't prescribe in Tata Medical Center cannabinoids, but has had some psychological effects on the patients, and they kind of increase the pleasure of having food. So that sensation, that feeling actually has proven some effect in short-term improvement in the appetite. And with regards to anti-GDF-15, it's really a new molecule which has shown to some promising results in regards to weight gain. So you must be having more experience with that. We have never tried that.
Yeah, so from the other medical oncology, Dr. Victor.
Yes, sir.
Yeah, any experience with this cannabinoids?
No, 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 sir, not yet, sir. Not yet in the present. We have not used yet cannabinoids, sir. Only magistral acetate and olanzapine I have used till now. Maybe in future more trial will come, more data will come. Maybe in future we can use, sir. But till now I did not use, sir. Till now.
Okay. Okay. So I think this anti-GDF-15 also, these are not available.
Sir, I have one just question and experience from Dr. Godav also.
Yeah.
That in Delhi we have used some of the patient nandrolone, okay, in severe cachexia patient. So how is in experience nandrolone you have used, and how is the it is effectiveness?
We have not used nandrolone. So we have had cannabinoid oil, which we tried in some patients, but it was then not approved by DCGI. So then we stopped using that. So we had some effect with short-term effect with using that we had good patient response. But with regards to the synthetic cannabinoids, we unfortunately we don't have that in our uh, pharmacy. So we have not used it.
Sir, you have any experience anabolic steroid nandrolone in very
No,
cachexia patient?
no, I don't use anabolic steroids.
Okay, sir.
So these are the differences or the similarities, some of them, megestrol and olanzapine. The mechanism is totally different. And somnolence is common with olanzapine, not with megestrol, but thromboembolism and edema can be there with megestrol. And hyperglycemia mild can be there with megestrol, sometimes with olanzapine also. Olanzapine also controls nausea very much, not megestrol. So another case, 72-year-old with squamous cell carcinoma, performance status LCOG 4, survival expected very low, patient is barely eating, wife is distressed requesting TPN or stronger appetite booster. Now, this is a simple question. At what point does cachexia make a patient unfit for immunotherapy or chemotherapy? Is it something related to nutrition parameter or performance status or both? Dr. Sachin?
Sir, cachexia is multifactorial. That like that only this decision will also be multifactorial, sir. If the patient is bedbound with chronic malnutrition, and as the initial symptoms described, it appeared as a PS4 patient. So in this patient, sir, there will be best supportive care will be the way to go, sir. And for general patients who are cachexic or with poor PS, that is the cutoff for no more systemic therapy that we use.
So we'll go to Dr. Gaurav. This patient comes to your OPD on a stretcher, and same the wife says that patient is rarely eating. So what do you do?
Sorry, sir, can you get back to the case again?
Yeah. Prognosis, we can say like 3 months we can take, 2 to
Yeah.
3 months, and not fit for any chemotherapy, targeted therapy, anything, only supportive care.
Yeah, we do see such cases commonly where, the emotional urge for of patients' family members to start that white colored fluid, with the thing that, खाना नहीं दे पा रहे हैं, but we कुछ तो IV आप दीजिए. तो उस तरह से we do get such scenarios very commonly, but we strictly follow guidelines about TPN in such patients with a very limited survival is more harmful than beneficial. And the SPEN guidelines also state that TPN should be given if we are planning for some definitive surgery or chemotherapy. Patient survival is more than 6 months, something like that. So we follow that guidelines. We try to explain and counsel the family members that, with regards to the risk of electrolyte imbalances, risk of infections. So these are there with TPN, and so we try to counsel them and communicate to them that the body's basal requirement is such that they don't require such high end products, and this won't benefit the patient. So that is how we prognosticate the family. And with regards to using agents in such patients with survival less than 2 months, we wouldn't go for a magistral acetate. But I have seen in my practice that giving steroid at a dose of 4 to 16 milligram usually brings about an acute improvement in the general well-being for the patient. So instead of magistral acetate, which does not bring about any change.
Right. So very good points to remember for practice, and we should not give them TPN in this kind of patients. What about NG tube?
Yeah, NG tube, we have to actually assess the risk of aspiration, and NG tube uh, can be provided as per the clinical status of the patient. So uh, we do that insertion of NG tube and Ryle's tube feeding.
Right. So I think we are coming to the end. The time is also up. So these are the expectations which we need to frame with the patient and family. The appetite improvement is not equivalent to the reversal of cachexia. Symptom palliation only or disease modification also, like anti-cancer therapy, and avoiding unrealistic expectations and align the treatment with the prognosis, like just we discussed. A terminal patient, don't use TPN. So nutrition, exercise with the realistic goals, obviously, and addressing the family distress around eating. So if the patient is not eating, family members also feel very much distressed. And early recognition is very much important. The drugs are all palliative, not curative. Multimodal care is required, and communication is a core intervention. I think that's all from our side. Thank you to all the panelists, and over to the organizers.
Thank you so much, Dr. Indranil sir, and our esteemed panelists for such an insightful and highly engaging discussion on cancer cachexia, an area which often remains under-recognized and under-discussed despite its significant impact on the patient outcome. I would once again like to extend my sincere gratitude to all our speakers and panelists for their time, expertise, and active involvement. With this, we would like to move on to the second case presentation, and the second case presentation is on real world case presentation on ovarian cancer. The moderator for the second case presentation is Dr. Jogmaya Patnaik ma'am. She is a medical oncologist at Kalinga Institute of Medical Sciences, Bhubaneswar. Dr. Jogmaya ma'am, would you like me to introduce the panelist or you will do it?
You can introduce.
Okay. So let's move on to the panelist. So the panelists for the case presentation are Dr. Lipsita Samantri. She is a medical oncologist at Some Hospital, Bhubaneswar. Dr. Manvi Suman, medical oncologist at HCG Hospital, Ranchi. Dr. Shushmita Sadhukhan, medical oncologist, Tata Medical Center, Kolkata. And Dr. Chinu Jomi, she is a medical oncologist at Manipal Hospital, Siliguri. So over to you, ma'am, Dr. Jogmaya, ma'am.
Thank you, Ms. Anjana, for this introduction and introducing my panelist. So I would like to thank you, the entire Samarth team, for arranging the program of Osmosis. Osmosis, I have been a part of Osmosis for some time, and this is actually a very interesting platform, online platform to discuss and interact with colleagues. So it's really a good, I mean, enriching experience always to be a part of it. Thank you so much, the Samarth team.
Thank you so much, ma'am.
So let me share my slides. Hope my slide is visible.
Yes, ma'am.
Yes, ma'am. Yeah, okay. And my panelists, Dr. Lipshita, Dr. Manavi, Dr. Sushmita, and Dr. Chinu. I'll go in the same order. So the first case is this is an entirely one case only, and we will see the different phases of treatment, which is actually a case which we see in our day-to-day practice. So it's a 50-year-old female without any comorbidities, without any significant family history of malignancy. She presented with abdominal distension and reduced appetite, which is a commonly seen case in our OPDs. So, Dr. Lipshita, this will be the first question to you is that what would be, suppose from the history, it looks like some abdominal malignancy, most likely. So what will be your sequence of evaluation, or what will test or your approach for this case? Dr. Lipshita.
Good evening, madam. Good evening, everyone. So my first approach would be, if we are thinking of some malignancy in this patient, my first approach will be a scan consisting of either a CCT, abdomen, pelvis, or MRI, depending on the blood test reports. The baseline reports being CBC, RFT, LFT. I would also like to check for tumor markers for the patient if I'm suspecting a malignancy. So CA125, CEA, CA19.9 would be my first blood tests. And depending on the tests and depending on the values, I would next go for the scopies if I'm suspecting some GI involvement. So scopies will include both upper GI endoscopy and ileocolonoscopy. So with that, I will know, do I have any GI involvement or not? Then the next would be ascitic fluid. If I have, then I can go for a ascitic fluid cytology and cell block to see if malignant cells are present or not, and if present, what type they are, whether they're suggestive of a GI or ovarian origin. So, and I would give IHCs on that. So these would be my investigations for the patient.
Definitely, this answers most of my questions, but we always need to make sure that we evaluate these patients completely, because many a times patients who will not have ovarian mass, may not have a adnexal mass, presenting only with omentoperitoneal disease and ascites, may have a abdominal tuberculosis. So definitely we always have to be careful about this, that we do not miss that diagnosis. Yeah, thank you, Dr. Lipsita. So the other evaluations were done, and this was the PET CT scan after the suspicion that it is a malignant GI malignant or abdominopelvic malignancy. So we did a PET CT and it showed bilateral adnexal soft tissue mass, hypermetabolic abdominopelvic peritoneal deposits, and moderate ascites. So, and the CA-125 was done and it was seen that 948. So it was quite elevated. So my next question to Dr. Manavi Suman is that, would you like to go for a biopsy at this stage, biopsy or a tissue diagnosis at this stage?
So, hi, ma'am.
Yeah.
So basically, the patient is having ascites, I think. So
Yeah.
we can send the ascitic fluid cytology and cell block. And if both turns out to be negative, then we can go for biopsy
Yes.
and
So
IHC.
ascitic fluid cytology actually gives us a very early report
Yes.
and very fast diagnosis with a high CA-125 level. So we definitely rely mostly on ascitic fluid cytology, that if it is positive, then we will go for a neoadjuvant chemotherapy. Oh, thank you. Then next question to Dr. Susmita. This looks like stage 3 ovarian cancer, bilateral. We take as bilateral ovaries are enlarged, CA-125 is high, and the ascitic fluid cytology is positive, and the scopies, endoscopy, colonoscopy, both were negative for any GI malignancy. So my question to Dr. Susmita is, what is your treatment of choice? Would you like to consider the tumor board discussion at this stage? And what will be your plan of chemotherapy or surgery first? What will be your plan?
So definitely this is a case that needs to be discussed in the tiny tumor board. So if the surgeon is comfortable to saying that they can achieve a optimum cytoreduction, so we can go ahead with the directly with the surgery. However, considering the other factors, mostly this patient will require an CT. And if the tumor board decision is in neoadjuvant chemotherapy, then we have to start with the neoadjuvant. But before starting a neoadjuvant chemotherapy, I would like to do a omental if deposit is there, then I would like to have a biopsy from the omental deposit and start my chemotherapy. And this is a if the initial cytology report says that it's a high-grade serous carcinoma, so definitely we have to go for the genetic test as well, that is HRD testing, or a minimum of at least the patient financial issue, the minimum germline BRCA testing. Followed by, I would like to start with the platinum doublet chemotherapy. So minimum 3 cycles followed by evaluation.
Good, great. So most of us also do the same thing. So my question to you is that, would you like to send the germline testing at the time of diagnosis? Suppose this is a confirmed case of ovarian cancer. Would you like to send the germline testing at the beginning, or you want to send it after the surgery when the tissue is also available and the blood sample also can be taken? For example, like take it that the patient is going to undergo interval cytoreduction. You
So
send
now
it at the beginning, or you
routine procedures in our institute to send a germline BRCA, because most of the patient cannot afford an HRD. So it's actually we do any reverse procedure. Ideally, it's a HRD testing, I should say, from the pre-chemotherapy biopsy sample. But because of the all practical purpose, we send a routine germline BRCA. If germline BRCA is negative, then only we proceed with the HRD. Otherwise, if germline BRCA is positive, then we send for the genetic counseling, and along with that, we will discuss the maintenance treatment as well.
Yeah, good. So, as Dr. Sushmita has already mentioned, that most of these kind of patients are not operable in the upfront. Bulky omentoperitoneal disease, a lot of ascites, in that the patient's general condition also will not be very good, nutrition will not be very good, albumin levels will be low. So in those cases, mostly the surgeons tell that we try to give neoadjuvant chemotherapy. So there are many trials which have showed that neoadjuvant chemotherapy is not inferior to primary cytoreductive surgery. So many trials, it has not proven that it is beneficial or it is superior or it gives more PFS benefit or more overall survival benefit, but it has been shown in various trials that neoadjuvant chemotherapy is not inferior. Okay. So our point is always, so whenever the patient can undergo surgery or a R0 resection is possible, then the surgeon can operate. Like, for example, patient has a large ovarian mass and not much of omental disease, not much of ascites, and it's not a bilateral involvement. So in those cases, usually the surgeons, we discuss in our tumor board, and the surgeon takes over for the primary cytoreductive surgery. Otherwise, mostly today's norm is that if bulky omental or peritoneal disease is there, then usually we go for neoadjuvant chemotherapy. Okay. So I think this we have discussed already that mostly these lesions doesn't look like resectable. So we go for neoadjuvant chemotherapy. So this patient was started on neoadjuvant chemotherapy with paclitaxel and carboplatin with bevacizumab based chemotherapy, and it was continued. So my next question to Dr. Chinu is that what is your practice in neoadjuvant chemotherapy in advanced ovarian cancer, high-grade serous? That means stage 3, stage 4. Do you add bevacizumab or you just continue platinum doublet? Dr. Chinu.
Good evening, ma'am.
Good evening.
So usually in our practice, we start the first cycle with only chemotherapy, and then we assess the tolerance and the condition of the patient after the first cycle. Upon reassessment, if the patient had upfront presented with ascites or stage 4A disease, then I would consider adding bevacizumab from the second cycle, and maybe stop it 3 to 4 weeks before the planned surgery. So we usually do our cytoreductive after maybe 3 or 4 cycles, ma'am.
Yeah, that is the common practice. As for the ICON 7 and GOG 218 trial, the patients who were treated with primary cytoreductive surgery, if they have residual disease or patients of stage 3, stage 4 disease, they were treated with taxane, platinum and bevacizumab and continued almost for 15 cycles of maintenance chemotherapy, which has given numerically better OS and a definitive PFS benefit. So definitely bevacizumab comes in the picture when the disease burden is high, and particularly in patients who have very refractory ascites. I'm sure everybody of you have seen in your clinical practice, there are some patients in which even if you start 1 dose of chemotherapy, then also the ascites tends to come back. Every week, at least once or twice, you need paracentesis for this group of patients. So when we add bevacizumab to this group of patients, actually that works better compared to only platinum-based chemotherapy. So our primary, if the patient has undergone surgery, so stage 1A, 1B, grade 2 observation is one option, but grade 3 onwards there is no observation. And any patient grade 3 endometrioid serous high-grade carcinoma, stage 1B, grade 3 onwards, platinum-based adjuvant chemotherapy is the treatment of choice. And whenever there is stage 3, stage 4 disease, high burden of disease is there, then definitely, or recurrent ascites, then definitely bevacizumab should be added to the chemotherapy. So next question to Dr. Lipshita. I'll go back, rotate my question to Dr. Lipshita. I will go back. So what is the next step? Like how you will proceed? For example, you have done germline BRCA and the germline BRCA has come positive. So what will be your next plan for this patient? Will your plan change or it will be same?
So now the patient has received 3 to 4 cycles of chemotherapy.
Yeah.
Next, we will reassess for surgery. She has to undergo complete cytoreductive surgery, interval debulking surgery, and then we have to complete the chemotherapy. Then we can put her on PARP inhibitors for BRCA mutation.
Okay. So this patient had shown PET scan showed partial response. CA125 has normalized. If you remember that it was 978, now CA125 is 30. Clinically also patient has responded and the PET scan also shows partial response. So we refer the patient to surgery. So now, next the patient underwent cytoreductive surgery. It was an interval cytoreductive surgery, and a complete cytoreduction was possible. So next question to Dr. Mannavi. I think we have already discussed that BRCA1, BRCA2 and HRD, at least BRCA1, BRCA2 germline has to be sent during the diagnosis or whenever it is possible to send before the patient going for surgery. So a germline test can be sent, and if it is positive, then further the other like somatic and all we may not send. So my next question is that Dr. Mannavi,
Yeah.
what are the
Yes, ma'am.
what are the molecular tests you will send? My questions are: you send germline, then you send somatic, or if germline becomes negative, then you send somatic, or you send both together, and what is the timing you send? Either you send it from the beginning or you send, for example, biopsy is available at the beginning. Do you send it from the beginning or do you send it after the surgery? So what is the timing and what are the tests?
So, ma'am, if most of the patients here are not affordable, so if affordable, then I would offer the testing at the time of after the surgery only, HRD testing and the germline BRCA. And if they are not affordable, then I will do the germline BRCA test upfront only. But most of the patients are not affordable, ma'am.
Okay, suppose it is affordable, then what will be your, suppose patients are affordable and we are discussing an academic scenario.
So we will do the germline BRCA test and HRD test at the same time.
Okay, at the beginning.
Yeah.
Okay, fine. So Dr. Sushmita, I think she has mentioned that she will send the germline BRCA test at the beginning. So what will be your plan if the germline BRCA comes negative?
Germline BRCA negative, so I would like to do a HRD testing.
You would like to do the HRD testing. Okay, okay. So it is, do you like to send the both the, for example, the germline testing and the somatic testing, suppose tissue is available, do you like to send the reflex testings, like if
Yeah,
germline is
actually that
negative?
should be the ideal HRT testing you should send if it is a
Yes.
comes actually that is the recommended thing, but because of the financial constraint we are sending, because the treatment will be similar kind of thing, so that's why we yeah, financial reasons we are sending the germline BRCA for all patients.
Correct. So we are a resource limited setup country, so therefore our tests should be sequential. So it should not be like we send the all the tests at a time. If the finances permit, definitely reflex testing should be ordered. But if the finances are a problem or constraint, then first we send the germline, at least germline BRCA1, BRCA2 to be sent, and if it is negative, then only we should send the HRD testing or the somatic BRCA mutation testing. So, ovarian cancer profile, actually, we all know there are high grade or low grade varieties, and their clinical features are actually different, and their molecular profile is also different. Like, for example, the histological subtypes like low grade, mucinous, endometrioid, or clear cell carcinomas, their mutation, they may harbor the mutation of PTEN, BRAF, KRAS, CTNNB1, and PIK3CA. They are more common. Type 2 is there, high grade carcinosarcoma or undifferentiated carcinoma. So they harbor most commonly the pathogenic mutations of PP53 and pathogenic germline mutations of BRCA1, BRCA2. So they are more common in the high grade malignancies. So therefore, the high grade ovarian cancer, their the molecular genetic testing like HRD, BRCA, whether mutated or wild type, that adds to the impact of medical management. So surgical management, if we see whether the surgical management is different or not, there are some evidences that if patient is BRCA wild type, then the surgical management like the complete surgery is possible, or some trials. So for example, I will ask this question to Dr. Chinu. Do you feel that there is a need for seeing or serial monitoring of ctDNAs or CTCs in ovarian cancer? Will that be of clinical utility or benefit? This is my
So,
question to Dr. Chinu.
right now, I don't have we don't have any standardized platform to do a CTC for ovarian cancer, at least where I'm practicing right now. So I have not done it, but maybe in the long run, like in hematological malignancies where we see the measure MRDs and all, maybe it can come as a marker later, but right now I am not very familiar with the concept.
Yeah. So there are many cases in which we commonly monitor the patients of ovarian cancer with a single marker, that is serum CA-125 or a ratio of CA-125 and serum CEA. But many a times the serum CA levels at the baseline are not very high. Even in high-grade ovarian cancer, so sometimes we find that the serum CA-125 levels are not much elevated. So those cases, it is very difficult to monitor, like whether the CA-125 is coming down or it is again increasing. So it is very difficult to monitor if it is not elevated in the baseline. So in those cases, we can use liquid biopsy. And in cases where the CA-125 actually doesn't work properly as a marker, as a prognostic or a predictive marker. So in those cases, we can actually use liquid biopsy, but it is hypothetical, not in clinical practice. But the point is that when CA-125 is not the marker, there like mucinous carcinomas, like clear cell carcinomas, in carcinosarcomas, so the CA-125 will not be elevated. In those cases, actually, in future, liquid biopsy may be of a use because it can detect the early relapse, it can predict the response to treatment, it can detect the recurrence, and also prognostication also, like initially we see what are the like MRD level, we can see the what are the genes that are mutated, then those genes will be followed like a serial monitoring. So this can be done to find out an early recurrence. So next question is that the impact of molecular testing in surgical management, like we have seen that resectability in first line and recurrent setting. If we see, there are some cases which show that BRCA mutation, some trials which show BRCA mutation doesn't predict the optimal surgery. Some trials are there which show BRCA1, BRCA2 mutation has improved the first line treatment resectability. But post-operative residual disease is the sole prognostic factor, even in BRCA mutated patients, after a multivariate analysis that has shown that it is bad prognosis in BRCA mutated patients. So the choice between interval and primary cytoreductive surgery doesn't matter. Both are almost similar. But after the cytoreductive surgery, if there is no residual disease, the olaparib maintenance has shown benefit according to the various trials that we already know. That SOLO-1 trial, PRIMA trial, all these trials have seen that the PARP inhibitor maintenance mostly works better when there is no visible disease or optimal cytoreduction after the cytoreductive surgery, be it interval cytoreduction, be it primary cytoreduction. And if I say that HIPEC, then definitely in BRCA wild type patients have benefit more for more with HIPEC, because it's not known, but it usually wild type patients, they benefit more from HIPEC. So next question. Yeah. So this patient had BRCA2 mutation positive. So my next question will be to Dr. Lipsita. What will be the next plan? So now this is germline BRCA is positive. So this BRCA2 mutation is positive. So what will be your next plan?
So since she's germline BRCA positive, so we need, so she's a confirmed case of BRCA mutation. So after the primary give NS neoadjuvant post surgery, we complete the adjuvant therapy, and then we can put her on maintenance PARP inhibitor, that is olaparib, which will give her an OS benefit for 2 years. We will give 300
As
milligram
you,
BD for 2
Dr.
years.
Lipsita, as you can see the histopathology findings, there were very less response to chemotherapy. So this large residual viable disease and metastatic tumor deposits in the wall of appendix and sigmoid colon. There are nodes. So do you
So
like
in this
that if
case,
bevacizumab was not given
yes,
before, you want to add it?
yes, ma'am. since the residual disease tumor burden is high, we can add bevacizumab along in the chemotherapy setting, in the adjuvant setting, and then we can put her on olaparib plus bevacizumab in the maintenance setting.
Yes. So if we start the patient from the first cycle itself, if we start the platinum doublet plus bevacizumab maintenance, definitely we have to continue after the surgery also. And as for the Paula trial, we can continue it with olaparib maintenance because this patient is a BRCA2 positive. But only thing we have to remember is that cycle 3 and cycle 5, we cannot add bevacizumab because there will be a chance of complications related to wound dehiscence and complications related to the surgery. So this we have already answered. So before the response assessment. So my question to Dr. Mannavi will be that how many cycles of bevacizumab we want to continue? You want any response assessment in between, or like we have agreed that the treatment will be bevacizumab maintenance along with that olaparib for 2 years. So how many cycles of bevacizumab you want to continue and any response assessment you want to do in between? This will be the question to Dr. Mannavi.
So, ma'am, was this patient HRD positive? I don't think HRD test was done for this
It was
patient.
not done. It was BRCA2
Okay.
positive. It was not done.
So, if we have used any bevacizumab in the neoadjuvant setting, then we have to add it in the adjuvant setting. Or if the patient had an R2 resection and there was a gross residual disease, then bevacizumab can be added for the patient. And
Yeah.
at least 1 year, 15 cycles, we
15
can,
cycles.
yeah, we can give as a maintenance bevacizumab and 2 years of olaparib.
Perfect.
And we can do a CA125 every 3 monthly to see if there is any progression which we don't know, and check for any additional symptoms the patient is having, because the disease is much left about post surgery.
Poor response to chemotherapy.
Yeah.
Good. So, if the CA125 starts, for example, the CA125 starts rising after 6 cycles, but patient is not symptomatic, and you did the scan and scan is not showing any evidence of disease. Would you like to change the treatment?
No, in that case I won't change, because patient is not having symptoms and CT scan is not showing disease, and C125 is just rising. That will not alarm me. But if the C125 is rising, patient is having symptoms and CT is also showing disease, then only I'll change the therapy. And if the patient is having a recurrence after 6 months, then we will again give a platinum based regimen. And if it is within 6 months, then we have to treat it as platinum resistant patient.
So about the maintenance regimen that we have already discussed, Dr. Susmita, what will be your maintenance regimen for this particular patient? What are the things we can give amongst all the options?
So the patient was initially started with bevacizumab plus carboplatin paclitaxel.
Yes.
So I would like to continue bevacizumab maintenance along with the PARP inhibitor. Any of the PARP inhibitor we can use, but regarding the as the olaparib is the most commonly available, as generic is available, that is the most commonly used. So olaparib plus bevacizumab will be maintenance therapy for these patients.
So
Dr.
there are
Jogmaya,
many trials for adjuvant PARP inhibitors like solo one. Every trial has shown PFS benefit compared to the comparator or not giving any PARP inhibitor. So solo one trial, the maintenance was olaparib maintenance in all BRCA2 and BRCA1, BRCA2 positive cases. So Paula 1 used olaparib and bevacizumab in BRCA1, BRCA2 mutated patients, and those patients who are HRD positive also were included. Prima trial has shown that it improves the niraparib maintenance, improves the PFS in HRD positive and BRCA1, BRCA2 mutated patients. Similarly, the trial that is for Velia trial, which is for veliparib, that also has shown that BRCA1, BRCA2 and mutated and HRD positive patients improve with veliparib maintenance. Okay, so this is the NCCN recommended options after the first line of chemotherapy if the patient achieves CR or PR. So bevacizumab They are all indicated in stage 2 onwards, stage 2 and stage 4. Stage 2 data is not very strong. Mostly the data of stage 4, stage 3 and stage 4 is strong, that we can use it if the patient has achieved CR or PR after the platinum-based chemotherapy. Bevacizumab, olaparib, as per the Paola trial, niraparib, as per the Prima trial, bevacizumab maintenance, and olaparib, as per the Solo 1 trial, are the treatment of choice. And the other drugs like niraparib and rucaparib also, as per the Athena mono trial, we can use as the treatment option or the maintenance option. So if we see VEGF inhibition and PARP inhibition, that has been combined in Paola trial. VEGF inhibition maintenance was seen in GOG 218 trial, that has shown a PFS benefit of 10.3 months, but addition of PARP inhibitor maintenance has further increased its 14.1 months, but the bevacizumab maintenance along with PARP inhibitors has improved further the PFS. So we will go see the Paola trial. It is a randomized phase 3 trial in which the newly diagnosed ovarian cancer patients with PR and CR after upfront or interval cytoreduction was exposed to platinum taxane-based.
Jogmaya ma'am,
Yeah.
I'm Dr. Avinash. Ma'am, can we do it fast? Actually, we are waiting for our session. It's already 8:45.
Yeah, I will finish it. Yeah.
Please, thank you.
Yeah, sure. So in which olaparib and bevacizumab maintenance has improved actually the 5-year overall survival, which was 47.3 months compared to 41.5 months. So we all know that in HRD positive group and in the BRCA1, BRCA2 mutated patients, Solo 1 and the Paola, they have shown the better benefit. So then the patient had completed adjuvant chemotherapy on bevacizumab and olaparib maintenance therapy. And this we have already discussed. So the common toxicities, I will ask Dr. Lipsita, what are the common toxicities of olaparib we will look for?
Anemia, fatigue, nausea, vomiting,
Okay.
and neutropenia.
Okay. So how we will manage, this will be a question to Dr. Mannabi, how we will manage the common toxicities of olaparib?
Yes, ma'am. So as of now, I have not seen much of anemia as we regularly see in the trial setting. So if there is any anemia, we will do the dose reduction, is what we can do.
Okay. And how long you will see for the anemia? Like how long you will monitor to see the anemia? And would you like to evaluate if the patient has recurrent anemia? Would you like to evaluate the patient for myelodysplastic syndrome also?
So truly speaking, ma'am, I have not seen any patient in my setting, any anemia, any grade 1, grade 2, grade 3, grade 4, any anemia I have not seen. So if any patient has anemia, then definitely I will do the dose reduction, and till the hemoglobin becomes normal, I will start with the lower dose.
When it is grade 1, then you can restart. Okay.
Yeah.
Okay, so the conclusion of my presentation will be the universal germline BRCA and somatic HRD testing are mandatory for all ovarian cancer patients. For positive patients, definitely family counseling and other genetic testing has to be done. Maintenance PARP inhibitor plus bevacizumab is the standard of care with advanced high-grade ovarian cancer. And in recurrent setting also, it can be considered irrespective of the BRCA mutated status in platinum-sensitive relapse patients. Toxicity management is priority, but mostly it is not very difficult. Thank you. Thank you so much. Over to the Samarth team.
Thank you so much, ma'am, for a presentation which was highly engaging and an insightful case study. And we would like to also extend our sincere appreciation to all the esteemed panelists for such a comprehensive and enriching discussion. Dr. Jogmaya ma'am, as you already said that you have been associated with Osmosis for a very long period of a time, we would like to again thank you so much, okay, and your continuous association and contribution along with those with the respected faculty members as well. So with this, I would like to move on to the next case presentation. And the next case presentation is on real world case presentation on prostate cancer, and the moderator for this case presentation is Dr. Amit Kumar sir. He is a medical oncologist, Medanta Hospital, Patna. And the panelists for this case presentation are So would you like to introduce or should I do it?
Yeah, you can.
Okay. So the panelists for this case presentation are Dr. Prashant Pandey. He is a medical oncologist at Tata Medical Center, Kolkata. Dr. Chandrasekhar Singh, medical oncologist, HCG Hospital, Ranchi. Dr. Devdeep Samdhar, medical oncologist, Manipal Hospital, Kolkata. And Dr. Avinash Upadhyay, medical oncologist, Paras Hospital, Patna. So with this, I would like to hand over the session to Dr. Amit Kumar, sir. Over to you, sir.
Yeah. So, So thank you, Samarth team and Osmosis team. So I think we are already late, so we'll be going somehow fast, but we'll cover the important parts of metastatic hormone-sensitive prostate cancer. So I'll just start with a case. A patient of a metastatic diagnosed as a prostate cancer. Basically, he's a 63-year-old gentleman diagnosed in the year November 24 with the PSA was more than 100. He presented initially with increased frequency of micturition for 2 weeks, urinary incontinence for a few weeks, and for which he has to get catheterized. And thereafter, he has a UTI features also, having fever on and off, and presented with decreased appetite. On evaluation, found to have a PSA more than 100. Then the biopsy has been done, which shows adenocarcinoma, DSN4 plus 4. It was a grade 4. The patient then underwent a PSMA PET, which shows lung mets, multiple bony mets, mediastinal lymph nodes. And the ECG depicts something right bundle branch block, and the echo is 60%, with a past history of diabetes to this patient. So I'll just start with Dr. Prashant. So Dr. Prashant, do you get these kind of patient upfront in your setting, or it is a referred patient which you get from the urologist with this picture?
So generally we get the refer patient, Amit. Generally from the urologist, we get the patient. But this such kind of patient rarely presented to the OPD in our OPD.
Yeah. So mostly, I think the patient which presents are those who present with the bony pain or sometimes spinal cord compression. So those are in more advanced stage. So do you think evaluating these kind of patients? So once a patient present to you with a backache, a severe backache, or a neural compromise, and with a high PSA, so what are your next steps? So how you go for the biopsy of these patients?
So definitely, what we do generally, we send the patient for the trust guided biopsy. Okay. And on the same day after doing the biopsy, we start the ADT.
Yeah.
On the same day. Okay. And then we wait for the biopsy report, and then we are going to add whatever the treatment is feasible for the patient.
Yeah. So definitely. So and about the staging workup. So do you wait to start the ADT upfront, or you want to do
No,
the
for this patient, in this case, if PSA is more than 100, there are lung mates, multiple bony mates. These all are present. So definitely without the biopsy, by doing the biopsy only, we start the treatment with the ADT. And in the patient where there is no staging at all, in that case, we generally go for the PSMA PET. If the PSA is more than 10, then we go for the PSMA PET CT and the biopsy. After getting the staging done, and if the biopsy is done, without waiting for the report, we start the treatment.
I think that's most important. So coming to Dr. Chandrasekhar, so what oncological emergencies do you get a patient with a prostate cancer? And how do you manage these oncological emergencies?
Yes, sir. So it can be malignant, spinal cord compression, patient presenting with paraplegia. It is a oncological emergency. They might present with hypercalcemia if they have extensive bone metastasis. So these two oncological emergency we see with prostatic cancer patients.
And so how fast do you act on this? Means what are the initial investigation you need to just start treatment for these patients, and what kind of treatment you go for these patients?
So if, with malignant spinal cord compression, if duration of focal neurological deficit is less than 48 hours, then we try to decompress it to have, motor recovery. And if it is prolonged, then we can add some sort of local therapy in the form of radiation. One thing we need to keep in mind to avoid RH agonist if it is impending cord compression or bladder outlet obstruction, so that we can avoid flare phenomena. And most of the time we go with GnRH antagonist. Regarding investigation, we need to do MRI spine to look for the extent of compression, and we can treat these things accordingly. Yes.
So yeah, so that's the most important point which I want to take out, that even without a lymphoma, a patient with a solid malignancy can present with an oncological emergencies, and these patient has to be managed very fast. And even by giving hormonal therapies upfront in these patients can lead to a significant improvement. A patient presenting with a severe pain, you may see a drastic response in these kind of patients within some time. So this patient initially underwent a first went ultrasound which shows mild hydronephrosis with hydroureter also due to BPH, and the CT chest initially shows permanent nodules with minimal effusion and mediastinal standard. And thereafter, the patient has undergone for a PSMA PET, which has already been depicted before, that it showed the lung lesion and multiple sclerotic skeletal lesions of pleural effusion. So, and the supraclav or multiple nodes. So, Dr. Devdeep, how do you differentiate a patient with a bony mets when it presents to you between whether it's a lymphoma or a myeloma, or it's a myeloma, or it's a CA prostate? So, what comes first to your mind when you see a patient with a bony mets?
Dr. Amit, sorry to interrupt. Dr. Devdeep is not there actually today because of some emergency.
Yeah. Dr. Avinash, so you can take that.
Sorry, sir. What was the question?
I was just asking about a patient who presented with a diffuse skeletal mets. So, what things comes to your mind, and how do you evaluate, and what do you think that this could be the probable differential diagnosis, whether it's a myeloma or a lymphoma or a solid tumor like CA prostate or a.
So I will look for the clinical symptoms. Like in this patient, there is a complaint of, I think, lower urinary tract symptoms. So if LUTS is there and then bony mets is there, and the patient is more than 65 years of age, I will think of prostate cancer also. Like it will be one of the differential diagnosis. Apart from that, I look for the CBC, RFT and LFT values. So multiple myeloma, most of the time, what I get diagnosed is by the hemoglobin levels, and then I see the total protein and albumin and globulin levels. So clinical values, lab values, and then addition of radiology, that all helps in making a differential diagnosis in such cases to me.
Yeah, I think so. That's the most important point. That once the patient present with a bony disease, the important thing, look whether it's a lytic or a sclerotic lesion, and the important is the CBC and the initial basic investigation. The peripheral smear, whether it's showing a raised DSR or it's showing a Role formation, or if there's anemia along with that AG reversal, if you are getting. So you have to be very much vigilant, because these patients may have can present with an emergency like spinal cord compression, and you have to find out what is the primary diagnosis based on that, when to go for a bone marrow or when to go for a further tumor marker testing and a biopsy in the subset of the patient. So this patient, so confirmed to be a case of prostate cancer. So initially started on docetaxel and abiraterone, and post few cycles due to financial, some of the patient get lost to follow up, and he was taking low dose, started on a low dose abiraterone, that is 250 mg, which he continued for uh, 3 months period, and will continue for 1.5 years. Thereafter, he stopped treatment. Somehow he is a poor compliant patient, because he was fine to his was feeling better, and he stopped. And thereafter, he progressed after some time, and then started on the second line therapy. So before going to this, so coming to Dr. Prashant, so do you want to do any further investigation in these patients? Any further investigation on the biopsy or other things?
Yeah, we have done the biopsy. We should send the patient for the BRCA analysis, that is germline analysis, along with the HR tumor too. Okay. And if finance is not the issue, then we can go for the NGS too for this kind of patients.
So that's the most important thing. So because even we say that the role for these biopsies, the germline or the genetic test comes later on, but it's better to do in a fresh sample rather than in an archived sample, which you are doing after 2 to 3 years. So because these are not so dynamic, and once you get and it is seen that something around in the metastatic setting, around 12% of the patient may have a germline DNA repair mutation. In a localized, it is 4.6%, and maximum are BRCA2 ATM check to BRCA1. And what the prostate cancer consensus conference also says that you have to test for these testing, at least BRCA1 to MMR gene has to be done. And now germline has already told Prashant, doctor, you have to go for the NGS testing also in this subset of the patients. What to do, whether to, Dr. Chandrasekhar, so do you do the testing only for a germline testing, or you go for a somatic testing also in these patients?
Yes, sir. So now we have enough data, even in hormone sensitive setting of PARP inhibitors, if you get germline BRCA or HRR gene positivity. So ideally, germline and somatic both should be tested upfront if patient do not have any financial limitations.
Yeah, so that's the most important thing, because what we see with the germline testing, you may miss 50% of these patients who may be eligible for PARP inhibitors. And with the somatic, which detects most of this DNA damage repair cases, though they are expensive, but the germlines may be less. So it's better you go for the testing both. Somatic might be a sequential, but it's better to do both of these testing in the subset of the patients. So what we see with this castrate-sensitive prostate cancer, it is found to be an androgen-dependent cancer and is highly expressed on these cells. And ADT is a primary therapy of the prostate cancer. So the ADT which we use in here are either GnRH agonist and antagonist, which is already touched by Dr. Chandrasekhar. So where to use agonist or antagonist, or where to go for orchitectomy. And to prevent this flare, the flare has been used because so coming to Dr. Chandrasekhar, once again back to you. So you have already told if there is an oncological emergency, you start with a GnRH antagonist rather than an agonist. So how do you compare with us? Which modality do you think is the most fastest to act, with the agonist, antagonist, with prevention of flare like baclotamide, or orchiectomy or surgical castration?
So, sir, surgical castration we don't do nowadays. We have to, sometime interrupt ADT due to cardiovascular issues. So most of the time we do go for medical orchidectomy only. Now coming to agonist versus antagonist, there is some data that antagonist works faster in terms of PSA reduction as compared to agonist. But as you rightly said, most of my patients in my clinical practice are on agonist only. Only thing where I need to avoid is where patient has impending cord compression to avoid flare. Otherwise, I would use GnRH agonist most of the time. But yes, if patient is having cord compression, then antagonist definitely.
Yeah, so that's the important point, that we have whether to use agonist or antagonist. So Dr. Prashant, in your opinion, and how do you choose between agonist, antagonist, or a surgical procedure?
So basically, once again, we don't go for the surgical procedure like orchidectomy, but going for the agonist and antagonist, it depends on the patient profile. If there is a bladder outlet obstruction, if there is an impending fracture, so in that case, we generally go for an GnRH antagonist. And if there is no other thing, then we are going for the agonist. The important thing is that there is no difference in efficacy between the agonist and antagonist. Okay, but the time duration by which the testosterone become decrease, that is important. So in agonist, it's around less than 5 days. Antagonist, sorry, and in agonist, it's around 14 days. So definitely the patient who are on impending fracture and bladder outlet obstruction should go for the antagonist instead of agonist. Otherwise, there is no difference at all.
Yeah, so I think so that's the most important part, which is covered, that when there is impending obstruction, you need to earlier response, go for an antagonist rather than an agonist. The fastest decrease though comes with a surgical castration, but the patients are generally not fit enough to go a surgical castration immediately. There are few advantages of these surgical castration, that it is a one-time procedure, permanent procedure, and somehow we'll say it may be a cost-effective procedure also. But the cosmetic effect is the most important thing which happens with this, and the sense of losing an organ is the thing which prevents most of the patient from going for a surgical castration. and there are much more psychological issues are affected with this, and sometimes surgical site infections, hematoma, other things which happens with this surgical castration. With the medical castration, which has already been discussed, it is a non-invasive, and you may also, the important thing is about intermittent ADT. So coming to Dr. Avinash, so do you practice intermittent ADT anytime in your practice, or does the patient demand for this intermittent ADT?
I have not seen, like, initially when the disease burden is high, I do not advise for intermittent ADT. But yeah, ADT will have side effects like hot flushes, lipid profile derangement, and multiple things. So I generally do not advise in my practice intermittent ADT. But in patients like who are having like kind of biochemical relapse, or the disease burden is very less, and the patient is having a lot of symptoms due to ADT, in those patients, I sometimes advise to go for intermittent ADT.
Yeah, so that's important. So there are data that when you are using intermittent ADT, it is found to be non-inferior, but you have to be very much vigilant in these patients. And there are the drugs like now oral drug coming in picture like relugolix and others. They help you to go for this intermittent ADT, because if you are using a 3 monthly dose or a monthly, then you have to skip it. With relugolix, you can stop it in between, and with the going for the more than 4 half-lives, the patient may be found to be free. And the most important thing is the sexual dysfunction happens with this. So intermittent ADT, so few patients are having much more of a psychological issues. So if the disease are well controlled in these patients, you may plan for intermittent ADT also with this patients. So whether you have to select a GnRH agonist or antagonist and as ADT, it all depends the mode of administration. So we have seen they are subcute and intermittent. And the important thing is about monthly dose versus 3 monthly or 6 monthly. So it's you have to discuss with the patient. Even with the oral tablets, it's a daily dose. So everything has to be discussed and a shared decision which helps you about what to take. If we, as already been discussed, if we are comparing a degarelix versus a leuprolide, that is agonist versus an antagonist, degarelix was found to be non-inferior to leuprolide at maintaining the low testosterone level. The median PSA at 14 and 28 days, we say, was much more lower with degarelix than with leuprolide. So we may get an early response with degarelix. So it has to be used in either bilateral outlet obstruction or spinal cord compression or other things. But overall, it is both are found to be similar, but degarelix is non-inferior to leuprolide with this. And the oral agent, that is the relugolix, which has been compared in the HERO study with leuprolide, it also showed the difference of 7.9% in this study has shown non-inferiority, and somehow there is a superiority too coming with relugolix is happening with the sustained castration rate is going something around 96.7% as compared to leuprolide, which is 88.8%. So if you see the castration level of testosterone on day 4, it is 56% with relugolix as compared to 0% with leuprolide. So even this oral drug, you may get an early response with this. The side effect, that is the cardiovascular events, that is the major adverse cardiovascular event, is the thing which also helps you to choose between an agonist and an antagonist. And we see the side effects are much higher with a leuprolide or others. With a relugolix or degarelix, it will find it is found to be less. So the cardiovascular safety of degarelix versus leuprolide has been compared in the PRONOUNCE study also, which has shown this difference. So important thing, when you are utilizing first generation anti-androgen in combination with LHRH agonist to block testosterone flare, you have to use that for the initial 2 weeks, and then has to be used continuing using ADT through the treatment of the patient with metastatic disease. So Dr. Avinash, so do you think a single agent ADT is sufficient enough? And in which kind of patient you would prefer to use ADT alone in a metastatic setting?
Single agent ADT used to be like the treatment of choice when we did not have ARPI. But right now, if you ask, I'm not going for ADT alone, because there are newer ARPIs which are not having like side effects, and they have shown in studies that they are going to increase survival. So single agent ADT as a neoadjuvant therapy, sometimes we are using for locally advanced prostate cancers and all and adjuvant. But in metastatic setting, using single agent ADT, I don't advise.
Yeah. So that's the norm. So basically, though it has also shown a benefit, and many patients with a very low volume disease or a patient at the extreme of age, a very elderly who is not going to tolerate with anything and has a small volume of disease, single agent ADT might be beneficial for those and has shown a response. So coming to Dr. Prashant, so now we have a plethora of treatment, so whether it's a single agent, a doublet, or a triplet. So how do you select the patients for either of these treatment?
So basically, it depends upon the patient profile again. If the patient has a high volume disease, okay, that is synchronous metastasis. So in that case, we generally go for the triplet regime.
Yeah.
Okay, and if it is low volume disease, metachronous disease, so in that case, we go for dual therapy with the ADT plus docetaxel or abiraterone or enzalutamide, or there are a lot of ART where we can go for that. So this is our first line treatment for hormone sensitive prostate cancer.
Yeah. So that's one of the important point which he has covered about the high volume disease or a high risk disease. So the first time when the patient comes to you, do you calculate this high volume and high risk, or it is both
Yes.
more or less same?
Yes. No, we generally calculate high volume disease. Okay. And the second thing, there are a few data where it's shown those patients who have undergone NGS, and in those patients, if they have the high risk factor, in that case, we can go for the triplet therapy.
Yeah. So I'll just coming to the definition of this high volume and high risk. So which has been because we don't have much time, so we will go in slightly. Yeah. So these are the definition for coming from the charted and the latitude trial. So the charted trial has shown that the high volume disease is more than 4 bony mets, including one outside the vertebral column of pelvis, and or there is a visceral mets in this. Whereas the latitude shows that if there are more than 2 high risk features, that is either 3 bony mets, a visceral mets, or a grade 4. So this goes in the favor of this is the high risk. So the latitude has labeled is as a high risk, whereas the charted trial has shown is this is a high volume disease, but there are more than 4 bony mets and including one outside the vertebral column, or there is a visceral mets. So this high metastatic burden is equals to somehow high volume, mostly, which has already been discussed. So these have to be taken care in this subset of the patient, and the stratification varies on these. So Dr. Chandrasekhar, Dr. Prashant has already said using doublet in the patient with a low volume and a triplet with a high volume. So in your practice, are you still using doublet in patients, and what patients you are using doublet?
So, sir, if patient has a low burden of disease, like less number of bony mets, which does not fit into high volume criteria, and patient is having comorbid conditions where they are unlikely to tolerate triplet therapy, poor performance status, elderly patients, there I tend to use ADT with the ARPIs only. But if patient is relatively younger, fitter, less comorbid conditions, and having high volume disease in the form of visceral metastasis or more than 4 bony mets, then I tend to offer triplet therapy.
Yeah, so that's important. And if you are using a doublet, when you are using ADT plus docetaxel or ADT with abiraterone or an enzalutamide or a darolutamide in your practice?
Sir, doublet ADT with ARPIs, ADT with not docetaxel.
So ADT with docetaxel only you are not using in your practice. So Avinash, any change in your practice? So how do you select the patients for a doublet therapy, and what doublet you prefer?
Doublet, I see whether the patient is having diabetes or not, because I know there you need to give isolone. So abiraterone goes out. Apart from that, darolutamide, if affordable, I do add with ADT. Apart from that, if the patient is having high disease burden, I generally counsel younger fetal patients for triplet therapy, because triplet therapy like abiraterone, docetaxel, or darolutamide docetaxel with ADT has shown survival advantage. So young fitter patient, basically high disease burden, generally I tend to go for triplet. Otherwise, based on comorbidity profile, I do select for doublets.
Yeah. So I think so that's the most important thing, that about selecting the therapies where you are using a doublet and a triplet. So triplet is the norm which is now being used if the patient is fit enough and it's a high volume or a high risk disease. Else you may go depending on the performance status of the patient with a doublet. And what doublet you have to choose. So this is the doublet trial which show ADT plus docetaxel either from the GETUC 5, Charted, or Stampede. All have shown that ADT plus docetaxel has shown to be a benefit. And if you see the high volume versus low volume, so high volume disease with ADT plus docetaxel has definitely shown a benefit with a hazard rate of 0.63, with a median OS going to 51 months as compared to 34 months in this subset. Similarly, the GETUC 15 trial also shown this benefit is seen in also in both high volume and the low volume here. And in this Stampede trial, which docetaxel has been compared with the zoledronic acid arm, and shown that docetaxel improves overall survival and not the zoledronic acid. And when dosi plus zoledronic acid improves survival, but no obvious benefit of adding over docetaxel alone. So, Dr. Prashant, do you, in the hormone sensitive setting, are you using zoledronic acid? And if you are using it, at what frequency are you using it?
So we are not going using zoledronic acid, but definitely we are using denosumab. That is 260 milligram 6 monthly. Okay, that is not for the bony metastasis, just to prevent the osteoporotic changes that can be due to the ADT which we are using. So for the bony metastasis, we are not using any of the bone modifying agent or RAL calculators.
So that's the important point and most important. And what is the thing which we often see in our practice, that many patients with a hormone system by urologists, they are started on zoledronic acid or denosumab, they are receiving it monthly. So it should not be done because it hasn't shown even in the clinical trial any survival benefit. And it is only should be given in the osteoporotic dose, that is the 6 monthly, and not to be given monthly as being done with the other colleagues. So that is the most important point. So coming to the other ARPIs like abiraterone, so one has to be very much clear that as Dr. Avinash has told, if a patient has to be given steroids, you have to be very much one have to think about starting abiraterone. If the patient have a cardiac issues, you have to look for this drug again. With enzalutamide, there are also studies which have shown that if the patient has a CNS effects, you don't have to use enzalutamide because the seizure potentials are high. There's other drugs like apalutamide with diarrhea and other things which comes in picture. Darolutamide found to be the most safest, I'll say. Dr. Chandrasekhar, so are you favoring using low dose abiraterone? So now there are studies also which shows that
Yes, sir.
Yeah.
Where I practice, most of the patients do have financial limitation. So it is a good strategy to give low dose abiraterone with food. So most of the time I tend to prescribe 250 mg with food. Yes.
Yeah. So that's also now valid action, and now clinical trials are going on to see this low dose, and it has found to be beneficial. So the patient we have discussed also has received low dose and has gone for 1.5 years on this even low dose abiraterone, which maintained the quality of life, and even this and the outcomes are more or less similar, found to be non-inferior. So we'll skip the ADT, and so if we come to the ARPIs, what we have seen with darolutamide, they have all covered high volume disease and higher is something around 71%, and the benefit. So you have to take the side effect toxicity profiles, especially in consideration. And the best toxicity profile we see is with darolutamide, and the overall the response is also found to be the one of the best with darolutamide. Else, the cheapest versions and the generic versions are available for all, and depending on the patient's general condition, one can start with these drugs. So I'll just I'll not discuss the radiotherapy part. So yeah, So just moving, so we are getting later. So we have a last questions from Dr. Prasad. So once the patient progresses on the initial triplet regime, so what are the next options you plan with these patients?
So definitely we can use cabazitaxel. Okay. And we can, if there is another thing that is radioligand, that is PRT, we can go for this kind of patients also. Okay. So these are the option we can use because there is no indication for re-challenging ARPI. Okay. So patient who has received ARPI again to re-challenge, there is only one thing where abiraterone can be re-challenged. If in between the patient had received only abiraterone with the ADT in the hormone sensitive case, and we are using on progression, we are using docetaxel, then again we can use abiraterone as a re-challenge in a subset of patient who has the VR7 mutation spliceosome. Okay, in that case, we can re-challenge abiraterone. Otherwise, the other re-challenge of the ARPI is not, the data is not so much profound for that.
Yeah. So I'll say that's important. So we have left that aggressive variant prostate cancer, though that progresses even within 3 months, even all the therapies. So one have to be vigilant about those also. And the thing is about the BRCA mutation we have talked about. So when there might be platinums can be used sometimes in those subset of the patient, and especially with aggressive variant. Regarding sequencing of therapy, so one of the most important about ARPIs, which Dr. Prashant has already says, so it is not shown any much benefit. But post abiraterone, you can give enzalutamide, but post enzalutamide, abiraterone has got a very less effect. So if the patient has initially received a doublet, you may start with have started with either docetaxel, you may move to abira and then enja, or if they have started with only abira, you may go with enja and docetaxel in those subset of the patient. But post enja, abiraterone has not shown so good a benefit. So sequencing there lies. But the most important part is that if you have uses a triplet, then you may evaluate these patients for the lutetium therapy. So Dr. Chandrasekhar, so are you using lutetium therapy commonly in your practice? And when do you introduce the patient with this therapy?
Yes, so now we are getting data that even before cabazitaxel, you can use lutetium therapy. But in our clinical practice, most of the time we offer cabazitaxel first and then refer patient for lutetium therapy.
Yeah. So I think so that one of the most important therapy which is now being there and has to be introduced timely so that we can have the maximum benefit is the lutetium, which may start initial and the patient has progressed and thereafter. So Dr. Avinash, so what is your lines if the lutetium therapy is not available because it is at the cost is a major barrier in the subset of the patient. So if you have started with a triplet as you have said, so what are the second line and third line therapies you start with this patient? And do you think the role of PARP inhibitors anywhere comes here?
So I do think PARP inhibitors are great. If BRCA2 particularly is positive or PALB2, I have I think 2 or 3 patients who are doing. I think since 2.5 years they are on Rucaperi post ADT plus ARPI. So it's a great modality to use if the patient is having BRCA2 or PALB2 positivity. Otherwise, if the patient is not having this, then cabazitaxel could be an option. Um, Using ADT, ARPI, and docetaxel as frontline therapy, actually the choice of therapy remains limited. I believe PARP inhibitors, then cabazitaxel and PRRT. These are the therapies which we can provide.
Yeah. So I think so. We have Dr. Avinash has covered clearly that even after the triplet, you may go with other lutetium or a cabazitaxel, and thereafter you may again, depending on the NGS report, that time you may look for any other chance of adding a PARP inhibitors in the subset of the patient. Immunotherapy has got a limited role, but sometimes you may introduce that also, depending on the high TMB or other features which may be getting, or NTRK or other tumor agnostic markers if rarely comes. So still there is a role of NGS, and depending on that, the treatment has to be defined on that. So with this, I think so we can end. So anybody has got any questions, we can take that. Otherwise, we'll be stopping here.
So on progression,
Yeah.
in CRPC, whether you are going for the NGS test or BRCA analysis once again, if it is BRCA negative in the initial. stage?
No. So BRCA, if it's initially negative, don't have to do a repeat. But NGS might be if you are going for a repeat biopsy from some other site. So you are not going to do a prostate biopsy definitely next time. So if it might be a liver or some other site where it's easy to get a biopsy done. So you may go for these biopsy and say a few dynamic markers which may occur because there's a last period of time. So that you might be doing this after 3 to 4 years. So you may expect some changes, though the chance of getting is less than 5%. Definitely.
So new biopsy is not required.
Definitely not, but you may go ahead if it's your any accessible site is available for these patients, and it's a long period. I'd say that's a 3 to 4 lines from the initial start of therapy if it has happened. So you
But
may go for
in the BRCA study, if you go through that study, you see that there is this HRR is a dynamic one. Okay, so the patient who was in CRPC, who is in CRPC, actually 2/3 of patient may produce this HRR alteration. Okay, and there we can use once again the PARP inhibitor in that case.
Definitely, so the only challenge is the site of biopsy.
Site of biopsy, yes, of course. Getting the biopsy is very tough.
Biopsy. Okay. So I like to end. Thank you. So thank you to all the panelists. So over to the OSMOSIS team.
Thank you so much, sir, for a comprehensive and an insightful case presentation. And with this, I would like to hand over the session to Mr. Saurav Saha, our head of marketing from Samarth Life Sciences, who will be giving a vote of thanks and a concluding note. Over to you, Saurav.
Yeah, definitely. Thank you, Anjana. Thank you, Dr. Amit sir. It's been a long time after that we are again connected with the East chapter osmosis. So with that, I would like to announce that around 125 live audience today with these 3 case studies of ovarian cancer, cachexia, and prostate cancer. Fantastic presentations by all the moderators as well as the interactions and the insightful discussions with all the panelists. With that, I'd like to close today's sessions, and we'll see you again with this for the next osmosis. Thank you, everyone.
Thank you so much, everyone.